All right, in Billings, Montana, it's 7 a.m. and we've got 7 board members at the table, which gives us a quorum. So let's come to order. I don't see members of the public. Any members of the public with us this morning? Anybody on the phone?
Hold on, Jim, let me, hold on, mute you. Yep, thanks. Debbie's out there.
Great. Is Michael out there or just Debbie?
Just Debbie. I don't think Michael is.
Well, it's given the fact it's 3 a.m. in Hawaii, I doubt that.
I was going to tease him. I was going to tease him if he was there. Ask him which bottle of wine he was on at 3 a.m.
And he still hasn't sent us a picture.
Okay. Morning, Debbie.
See, we have some new board members. I see 2 of them already. Let's hold off on introductions and we'll wait till we've got more people in the room. Can I get approvals on the December, and we have minutes in front of us from our joint board member meeting. If everybody could review those quickly. I'd like a motion to approve.
Don't move.
Second.
All in favor?
Aye.
Thank you. The December 5 board meeting. Can I get a motion to approve?
Motion.
Second?
Second.
Thank you. All in favor? Or any comments or
Aye.
questions, changes? Hearing none. All in favor?
Aye.
Opposed, same sign, please. Mr. Forte,
All right.
you're up.
Thank you, Jim. First off, again, for those of you I haven't seen, Happy New Year. Welcome to 2025. We had a busy end of 2024, just closing things out and moving on from one of the toughest years on record here at RiverStone Health. From our financial challenges to Medicaid dips, we're moving forward and we're recovering nicely, as you'll see in our financial report later tonight or this morning. Still dark. Yeah. I'm in Hawaii with Michael. But as we enter 2025, RiverStone Health and the state of our organization is strong. We continue to focus in on expansion, adding patients and adding access to care, whether that's through school-based health centers, a mobile unit coming up, other places to provide outreach, or the strengthening alliance between our organization and our hospitals. We also continue having meetings with local and federal leaders. We've had introductory calls with our new freshman senator and representative. Been able to touch base with, with both Troy and Steve, with Senator Sheehy, and with others across the state to welcome them to Washington, D.C. for the 119th Congress. Have a conversation on what we actually do here in public health and community health centers and why we're going to need their support up on Capitol Hill. I was in Helena last week talking with our local delegation there and others. Met with Ed Luttrey, had a great Medicaid hearing yesterday. And then in 2 weeks, February 3rd to the 9th, I'll be in DC. And again, we'll have some meetings on the Hill with our delegation, every member from Montana. They are having Montana coffee again, talk to Senator Dane's staff. So we'll have a conversation and be able to meet the whole delegation on Wednesday morning, and then have meetings with them on the Hill on Thursday that week.
But John, you talked about a new mobile program. Are you partnering with the city on their mobile prices, or are you?
So I'll talk about that.
Okay.
Yep. But this is specifically to the clinic and mobile medical health, dental behavioral health. Yep. So we'll continue to make progress. We'll continue to advocate for common sense bills that help us provide the care that we provide. December 4th was the opening of our Billings Senior High Clinic. I know several board members were there. So thank you for your continued support. Again, that was made possible thanks to the $300K we received from the Montana Healthcare Foundation. Our RiverStone Health Foundation also received a $400,000 gift from the Fortin Family Foundation to continue that school-based healthcare expansion. So we'll continue to make good use of those funds. We had a utility outage towards the end of the year. December 18th, we lost a day of service in the clinic on the 19th. Tried to let the board know, as well as our community partners. Our phones were down, our internet was down, and we had quite the electrical blip due to a windstorm. We've been in contact with Northwestern Energy, and they have worked to resolve and remediate the problem. And so we'll see when the wind blows again, if we're in fact in a good place. I hope so. We fixed everything on our end to make sure that our generators activate correctly, and that we've put all of our IT systems now onto backup universal power supply, so that in the event of any future interruption, we shouldn't be as negatively impacted as we were on the 18th and the 19th. Moving forward, down into leadership, page 2, we've got, we had a great meeting on January 10th. We had the quarterly alliance meeting, continuing to build strong alliance with our hospital partners. And to Mark's point, we are continuing to build focus on behavioral health. Yes, sir.
So do we have any list of things the alliance has actually accomplished?
No. Other than our annual health needs assessment and healthy by design work and you know, public health prevention things. No. But I think that's something we're working on as an organization across the board, is end of year metrics and kind of a state of the union report, if you will, on what we've been able to accomplish. We also had a good meeting with the local governing authority, city and county elected leaders. We met to discuss behavioral health, review overdose data, discuss the dangers of unregulated substances like kratom and other designer drugs that are impacting residents. And we were thrilled to have Casey now as chair of that local governing authority. Thanks, Casey.
Thank you.
We're continuing to work with county and city leadership to take ownership of the state's crisis diversion grant. And Commissioner Morris, that's where the CRU comes in, local crisis response. There are 11 deliverables in that crisis response grant. We're taking on responsibility for 8 of those, essentially, working closely with United Way, working closely with Veterans Navigation Network and other partners. The Crisis Center has a component of CIT training. We're going to take on the coalition building, the partnership, bringing people around the table for solution generation. But mobile crisis is going to be a much larger lift. It's going to take multiple partners across the community. It is going to take coordination with law enforcement, EMS, fire department, and we're working to see what capacity our hospitals have, what capacity partners like 406 Recovery have, and what capacity exists out there across this community to help us staff a 24/7 or a 12/5 or whatever this community needs in terms of mobile crisis, to bring a whole community approach to this, because it can't just be one agency.
So have you had any discussions with city council over mobile crisis unit and what issues were, why it failed the first time? Or
Yes. Okay.
so you understand all that will go, it's how they're dispatched and
Yes.
who makes the decisions, whether they take the call and all that stuff.
Yeah, and we've got some best practices from across the state. We've talked to Lewis and Clark County, and we've talked to other partners out there and saying what works, what doesn't work, what do we need to change here? You know, we piloted it, we tried it, it failed. Now we need to move on and figure out how to make it right. So we're going to continue to meet with the city. We've got a meeting tomorrow with Jason Banfield and the fire department to kind of go through what happened there. And then we're going to come to Board County Commissioners, we're going to come to City Council. We're going to present a plan and an approach to say, how do we do this better?
And I'm sure you've done enough, you're on top of this, but Veterans Navigation Network, they, under the Crisis Diversion Grant, they came with an invoice and they could not produce the documentation the state requires. And sometimes you're never quite sure what that is, but I think they came back and they wanted to see personnel expenses or something. And BNN is, quite disturbed that they can't collect because they can't provide documentation. So I'm sure you know that it's pretty specific what the state will come back and ask for. And if you can't provide it to them, you're not getting paid.
Yeah, and we've got a meeting on the calendar, I believe, for next week with VNN to make sure we help them get their ducks in a row too. So we'll continue to try to be a good partner and bring people around the table.
Where will this ultimately reside? This mobile crisis unit. I mean, it seems like there are a lot of parts.
Short answer is, I don't know. The long answer is probably within some control of the health department with a partnership from the hospitals and another behavioral health provider. There's no one solution. There's no one person that can staff it. And that's been proven.
It seems like there are a lot of parts. And no accountability or leadership. That, I guess, and I'm not familiar enough with it, but just listening to you talk, wow.
And that was part of the struggle, I think, of the coalition of Substance Abuse Connect. We had a Billings Community Foundation. Thank you for picking it up, and Zach, thank you for trying to lead it, but it didn't have any oomph behind it, and as a private citizen, there was no authority or ability to herd the cats in a way that needed to be herded. So we
Can I maybe give you a little insight, county side on that?
Sure.
So Substance Abuse Connect, it's not really an entity, it's a coalition. There's no governing document, they have no structure, they have nobody who can hold accountable. And what we found at the county, I'm starting my third year as a commissioner. For 2 years, I tried to hold somebody accountable to provide a plan, tell me how you were gonna spend this money. Nobody could do that. And that's really on the Substance Abuse Connect. Unless you have governing documents, I just don't foresee that that's going to be a workable model unless you can have accountability and you can point to a document and say that's your responsibility to do something.
That's our goal. That's what we do in the health department. That's how we manage state contracts and grants now.
Well, I would give
And so-
you guys a perspective on that.
For sure. So that's why it made sense to Eric, Melissa, myself to say, hey, we ought to just take this on and we can provide some of that governance and accountability within this structure. So that's what we're going to try to do. Continuing on, we had a great well-being workbench survey and employee engagement survey completed at the end of the year. Just to highlight on our turnover, our employee turnover has averaged 11.4% over the last 9 years, compared to an industry average of about 36.6%. Our turnover for 2024, even in tumultuous times, ended at about 11% versus 12.8% in 2023. So it's clear that folks are still committed to this organization, to our mission, and that we're still doing our best to make sure that we support our staff. We'll have additional data once the data from both surveys is being analyzed, and we'll have an executive summary available that we'll bring to the board to talk about that. Let's see, and just going into public health report real quick. Flu continues to be an issue across Montana. 2 weeks ago, we had our first recorded flu deaths in the state. And those 3 first deaths were all here in Yellowstone County. Man in his 50s, woman in her 80s, and a woman in her 60s. All unfortunately passed away here in Billings. So far, there have been just over 2,600 reported flu cases, 165 hospitalizations, and we're now unfortunately up to 9 total deaths due to the flu. So we'll continue to monitor influenza. And then I provided a summary of 2024's COVID infections. Last year, we saw 17,713 confirmed cases. It's down from 25,675 in 23. Just over 1,100 of those were hospitalized, with only 74 reported deaths last year. So far in 2025, we've seen 545 total COVID cases, with 57 hospitalizations and unfortunately already 2 in January. So respiratory season, as Megan queued up,
Thank you.
is alive and well across Montana and Yellowstone County. Perfect time. Perfect time. So pending your questions, that's my report.
Any questions for John?
Thank you.
Megan,
All right.
tell us about COVID and the
Tell-
flu.
So I don't think my report got handed out. I apologize. I was away for 2 weeks and then came back and was sick last week and got it done yesterday. And somehow I thought it was sent to Carrie and it wasn't. So I have it in front of me. We can send it out to you, but I'll just give a verbal report. So, really, so as far as the medical staff update, we're continuing to try and increase recruitment. We do have 2 mid-level providers who are starting in the next couple of months to backfill some of our positions that some of the people who left this year. We've been talking, for those of you who are new to the group, about really the need to have a training, a residency program or a formalized training program for our mid-level providers. We're seeing a shift statewide to more mid-level providers. And there are lots of reasons for that. The big challenge is they really come out with significantly less training than our physicians do. And so trying to, and when we get new mid-level providers here, it's a big burden on our experienced physicians to really try and get them trained up. It takes a lot of time to get them trained and ready to perform independently. And so really having a formalized residency program that would have structure for that support would be not only beneficial to us and to our immediate region, but really to the entire state. The big thing we have, because of the Montana Family Medicine Residency Program, we have lots of those structures in place already, but we need funding to support that program. And so we're continuing to look for ways that we could fund really the infrastructure to support a program like that. But we've decided initially we were going to put a hold on all new grads just because of that, that burden, but we're kind of desperate. And so we're going to unload these 2 and sort of put them through the way we have put our previous new grads through. As far as residency is concerned, we have completed our residency interview season. We interviewed 114 in total. The rank list is due on March 5th. We will find out the match week is the 3rd week of March, so March 17th, and then we will know at the end of that week who our new residents are for this year. We also are working on, so we have an addiction medicine fellowship that's accredited. We kind of put that in place about a year ago. That's another program that we haven't had the funding to support that infrastructure. We've applied for several grants and haven't gotten it. Huge need. There's really only a handful of addiction trained physicians in our region. And this is a growing need. The treatment of substance use disorder is being pushed into primary care across the nation, really, understandably so. But we need more people who are trained as experts to help lead the primary care providers who are doing that work. So we have a residency program. We actually had an ACGME accreditation visit last week. That went well. We have been approved to continue to have that program accredited, and now we're in the process of applying for another HRSA grant that hopefully, if that gets funded, we'll be able to recruit our first fellow for the upcoming year. We'll recruit in fall for the following year. The residency rural track is another area that's been under development in the residency program. Number of pieces are still trying. We've had a planning grant for that. A number of pieces that are still at play there. We're still hopeful that we're going to be able to start recruitment for those spots this summer. Other things that I sort of highlighted, I talked about senior, I talked about the mobile clinic. So we have purchased and we are waiting for our first mobile unit to be delivered in February. That mobile unit, our plan right now is to start 2 days a week doing medical out in some of the rural schools that we have started to develop relationships with. We hope to be able to do 1 day a month, 2 days a week medical, 1 day a month dental right now, so that we're able to do some outreach dental. And then eventually we're going to bring mental health on board. We've been having a challenge recruiting mental health providers. And so we have an open position at senior that we've been trying to recruit, and we're pulling our behavioral health providers from here to go cover that position. And when we can recruit, our goal is to have by the end of the year a behavioral health provider in the career center, and then a behavioral health provider on this mobile unit that's able to do outreach to some of our surrounding communities. And then we're looking at, is there another way that we could potentially use that mobile unit to do home care, health care for the homeless, HCH, do more outreach out of that mobile unit. So we're really excited. This mobile unit has been honestly a dream of mine for a number of years. I'm really excited that we are finally able to get that going, and I think it's going to really expand our reach to communities that truly have difficulty coming in to access care into our main medical center. Medical encounters, as many of you know, this has been a conversation that we've been having about how to increase our medical encounters. We had a lot of changes in our staff, in our team model. With the RIF, we lost a lot of our support staff. But despite all of that, the way it's looking is that we increased our number of unique patients by about 650 this past year, and we increased our encounters by close to 8,000, 7,900, somewhere around there. Those numbers are not exact yet. Those are sort of preliminary numbers as we get our final numbers. So I'm really proud of our medical staff and our clinic that was able to do that despite all of the changes that we had this year that really put an increased strain on our resources. We are as we look forward, I think that from the clinic standpoint, I think one of the things we're really looking at is how do we relook at the teams that we have in place, relook at how we can maximize our efficiency and really get geared up so that we can get back to doing really great population health and quality and work on our quality numbers for this year, and increase some of the revenue that we get through some of our shared savings plans and our other quality incentive metrics, and just being able to provide that care. We had a great presentation yesterday. We have a metrics, quality metrics module called Azara that we've been using for quite a while to look at our clinic quality. And it has finally gotten to a point where we are able to roll that out to our whole medical staff yesterday, so that everyone now has easy access to pull up what their quality numbers are and be able to drill down to their actual patients who are not meeting those measures, so that we're able to do really focused outreach on our patients that are sort of falling through the cracks. And so that is a huge, thank you to the IT team who worked to do that, and to our QI team, Lauren, who really has been the leader of that. Child Advocacy Center, we're still working on getting the medical clinic up and going. We are one small hair away from being able to get that open. John mentioned the biggest public health issues right now, or the biggest communicable disease public health, concerns, which is really respiratory season. One other thing with that, there was a health alert newsletter network advisory that went out last week. So you have started to hear about H5N1, which is the avian flu. We've heard about that occurring sporadically in some humans in the United States, none in Montana, but in different livestock. We don't routinely test for that when people come in with influenza. And so there's been a guidance put out to really urge that with our sickest people with the flu, and if people have risk factors for avian flu, to make sure that we're doing subtyping that would help to tell us if we need to test for H5. And so that went out, and the state and medical providers are sort of figuring out how we're going to operationalize that recommendation. And with that, I will.
So Megan, what are mid-level providers, employees, contractors?
So mid-level, yeah, great question. Mid-level providers are nurse practitioners and physician assistants. And so we typically call them advanced APPs, advanced practice practitioners. So those are people who, so for medical school, 4 years of undergrad, 4 years of medical school, and then a residency program on top. So you're really looking at a minimum, 8 years of schooling and then 3 years of training. A nurse practitioner, for example, does nursing school. So 4 years of nursing school. They do a graduate program that's about 2 years. So they've done 6 years. And then they do, in Montana, they do 500 clinical hours to be approved to practice. So that's, 14 and a half weeks of clinical practice. And so, and PAs, 4 years of undergrad, they do 2 years of a graduate program. In their graduate program, they do about 9 to 10 months of clinical rotations, and then they go out to practice. Again, compared to a physician that does 8 years of training and then 3 years of clinical rotations in a supervised internship sort of environment. And so there's just, so mid-level is sort of an old term, which I really should retire, because it really is advanced practice practitioners.
And so are they considered your employees?
Oh, yeah. Yeah, we hire, so we have on our staff, we have medical, so we have physicians, both MDs and DOs. All of our physicians are on faculty at our residency program. And then we have a number of largely PAs. We have a couple of nurse practitioners, but we have a large number of physician assistants that work that work with us and are outstanding and are a critical member of our medical staff. But we spend a lot of time training them to make sure that they are, really providing, excellent quality.
And then what's your retention rate, or do they go on to bigger and better?
Yeah, that's a great question. A lot of people move on from here, there are actually very few. So if you look at the healthcare facilities in town, there are very few healthcare facilities that will hire a APP right out of school because of that lack of training, they haven't had all of the training. And so we have historically taken a lot of new grads, partly because we have, so our new grads come into a supervised environment with our providers. Every time we have residents in clinic, we have faculty members that are precepting those residents. And so even though the APPs, that's not the faculty's role, is to supervise the APPs, there's always a physician that is basically available to come ask questions too. And then we have didactics, which is part of our residency program, where every Wednesday afternoon we do additional training for our residents, and we fit our our new APP providers into that training program. What we don't do, and what we would like to be able to do, is have more dedicated supervisory support for the APPs, so that there's actually a dedicated, when they're starting to see patients, there's a dedicated person who's there to run things, to supervise those visits in a more formalized way and to formalize their rotations more. So we actually have 2 APPs who are on our inpatient team working as part of that team as physician extenders there. And so we have that opportunity to rotate learners or APP residents through that inpatient team as an inpatient experience, which would be amazing in all of our other sites. And right now we don't do that. We have an onboarding that lasts about 3 months, where they get a lot of direct supervision, and then they just start seeing patients independently with support and with some supervision, but much more independently. And we would like to be able to expand that. Sorry, that was a lot.
I would assume that the hospitals would be natural prospective partners for mid-level training program. That'd be correct, like they are for the residency.
You would think, yes. I mean, I think that yes.
Is the flu, can you tell yet if the flu, either of you can tell if the flu is progressing as anticipated this year?
Yeah, so we started a little bit later this year. At first when we heard there were 3 deaths all in 1 week, that first week, that was sort of, at first you were like, oh my gosh, like that's concerning, because the flu numbers had just started to go up. When we look at last season though, it wasn't too far off. It was actually right where we were with deaths at the same time the previous season. It's just that they had been spread out over several preceding weeks. So it's a little hard to tell right now. We are still on the way up. It started late. And so nothing is raising significant concerns that this is out of the ordinary, other than it really started a couple weeks later than it has in previous seasons.
And I'll just bring it up. That's the state APHHS dashboard. And so you can see there, this red line is 2024, 2025. And that's, so we're trending lower than we did obviously in 2022, and still lower than we had in last year in 2024 at this time. So we're right down there, almost on trend with 21, 22.
Thanks.
Yep.
Any other questions for Megan or comments? Hearing none, I'm going to go off script and let's handle introductions.
Yeah.
Is what?
RSV.
RSV, I think last week RSV was actually up a little bit, but that's not expected. We expect to see RSV go up and down really until the end of February is kind of RSV season. But if I'm remembering, week to week is hard to get excited about, because it really doesn't mean that much until you see a trend over several weeks.
The percent of positive tests
Went up.
has spiked.
Yeah.
So folks who are coming in are being diagnosed at a higher rate. But from a trend line, we're still well behind previous years.
Okay, introductions then. Mark, why don't you introduce yourself to the group?
Mark Morris, County Commissioner.
Nothing else.
What do you want to know?
Background a bit and what you hope to achieve down here.
So I was 31 years a special agent, then I retired when I was 50. I opened a PI firm. I went to work for the sheriff's office. I was a deputy. I got promoted from deputy to county commissioner. Mostly because of what went on down at Metro Park. And there's a county representative on the Board of Health board, and Don Jones was it. And I think what's going to occur going forward is that county commissioner is a 6-year term, and so you're always chairman your middle 2 years, year 3 or year 4. And so I think starting with me, what we've decided to do is the chairman of the Board of County Commissioners will always be the representative to the health board. And then that way there's some continuity. So.
Thanks. Erin, tell us a little about yourself.
I am Erin Lambert, and I'm the CEO at YWCA Billings. My pretty much entire career has been in the gender-based violence field. I've been with YWCA for 20 years this fall. I've had about 6 different positions there. So I started as a volunteer and I worked my way up to CEO. I do have a bachelor's in liberal studies and a master's in mental health counseling, but don't actually use that. I'm a mom of 3 and I'm Montana native. And I'm excited to be here. I'm really interested in the social determinants of health and looking at things like racism and gender-based violence, things like that as public health issues, and how I can bring my expertise to help address those.
Great. Good to have you both on board. Let's introduce ourselves around the table. Coach, you want to start?
John Doerr. I've been on the board now for 11 years, did orthopedics here for about 40 years, and coached high school and club soccer for 20.
That's the nickname. Jason.
I'm Casey Wheeler. I'm a city councilman in Laurel, and Laurel also has a seat on this board. So I'm the one because I'm a registered nurse. So.
Okay, we know you. You know me, Jim Harris, hospital finance.
Spencer Anderson. I'm been on the board now a little over a year. CPA, and currently work as a senior vice president at Yellowstone Bank.
Steve Warlick, I own the clock tower in Stellas. I started with RiverStone before the foundation, or right when the foundation was started. So I've been on the board, the foundation side. And then I went over to Board of Health, so.
Great. The staff, Megan.
Sure. I'm Megan Littlefield. I'm a med-peds trained physician. I have been here at RiverStone going on 14 years now. I moved here from the East Coast. I actually was brought here really to lead the patient-centered medical home movement at our organization here. I had a lot of experience doing that back at my former health center. I am the chief medical officer here. I'm the medical director of public health. And my clinical interests these days are really in the area of youth with behavior and development issues. I run the foster care clinic. I oversee the school-based health centers. I work a lot with the residents on these sort of high-risk youth. And I am now starting the medical clinic for our child advocacy center, which is a child abuse evaluation, Yellowstone County child abuse evaluation. We had a gap there in our county, and we are stepping up and doing that. And then I'm going to recruit people to do that for me. So I've been here. I've seen RiverStone through a lot of changes over the last decade and a half.
Jenna?
I'm the lawyer. I started
You're on our side though, right?
typically, depending on your point of view. Yeah. I actually was initially involved with RiverStone when I was the chief deputy county attorney, civil, and then that sold out and went into private practice. And I still get to harass everyone here, so it's kind of win-win. It works out really well.
Eric?
I'm Eric Owen. I'm the Vice President of Public Health and Clinical Services. I've been here for just about 3 years now. My background is working in health departments that operate federally qualified health centers or private not-for-profit federally qualified health centers. I've been doing that work for 20 plus years at this point. My role in the organization is to work with Megan. We kind of provide the executive operational and clinical dyad for the community health center, the public health department, and home health and hospice services. So my team kind of consists of all of the senior directors of those 3 departments in the organization.
Great.
I'm Bob Janicek. I'm the CIO. I've been here just a little bit less time than Eric. Spent about 20 years on the payer side of healthcare, and then had an opportunity to move to the provider side. And I'll say I do favor the provider side just a little bit. It's been a great experience. My areas of responsibility are, of course, IT, our quality and innovation team, our security and facilities, and risk and compliance. So kind of a hodgepodge, but they all tie together quite nicely.
Thanks. Shanna?
Good morning, I'm Shanna Zier. I'm the CFO here. I've been with the organization combined total about 8 years. Held other local community jobs, nonprofit jobs, banking, and so just have a finance background. But in about 8 years. Welcome, thank you.
Okay.
And sorry, Jim, we've got Debbie.
Oh, that's right. I'm sorry too. Deb Davis on the phone.
Unmute.
Still muted.
Do we have to do that? Sorry, Debbie, I think we might have to.
There we go. Can you hear me?
Yep.
Louder.
Oh. Now we lost you. Sorry, Deb.
You have her unmute again.
There we go.
Okay. Good morning, everyone. I'm Debbie Davis, and I'm on my 2nd term with the board. I'm a school nurse. I worked with Indian Health Service previously, and also with the National Health Service Corps and Homeless Program. So I'm fairly new. I'm still learning, but it's nice to meet you. Thank you.
Thanks, Debbie. And I think, you know what, for the new folks in the room, I will go ahead and just say, I started my career in a small community hospital in northeastern Pennsylvania doing admissions work on the front desk and in the emergency room. Then went to Scranton and got educated by the cast of The Office. Spent the next 10 years in the Department of Veterans Affairs in the VA health system. And then had an enlightenment moment and decided to go work in community health. And so spent a couple of years on the Eastern Shore of Maryland at a community health center. And then COVID hit and started doing some public health work. Got a call from a recruiter and here I am. So happy to be here.
We're happy to have you here.
Thanks.
Okay, Jana. Or I'm sorry, Spencer.
I mean, I'm happy to turn the time over to Shannon.
No, come on.
Right,
It's all due to you. Take credit.
We're turning over a new leaf today. So in the shadow of Jim and Jenna, I'll lead out. And if at any point I misspeak, by all means, feel free to jump in. So covering a couple of things in finance this month. We're going to start off with the Finance Committee meeting notes from December 2nd. That relates to the year-end financial audit and report. That are, if you maybe you don't know or not, but our fiscal year is through June 30th. So the financial reports relate to that period from May to June 2024. I think we won't go into any great detail on these, but I think at page 20, the next page in the packet is the summary of findings related to that particular audit. And the type of auditor report issued is unmodified. And so an unmodified report means that's a good audit. That means they had no reservations about the financial reporting or the internal controls related to the financial reporting. So overall, a very good audit. I think it's they not only review the preparation of the financial reports, but all the underlying internal controls related to the preparation of the financial reports. So it's actually quite a big lift for our staff on top of everything else that they do. So I think that's and I just tip my cap to them. That was a great result. With no findings and no recommendations, no material recommendations. If you're interested in reading the full comprehensive report, and have that available. It's about a 70-page financial document. There are no material deviations from what's been presented to the Board of Health in our regular monthly meetings. So you can, but if you would like a more in-depth review, you're by all means, that report is available to you. So, any questions as it relates to the year-end financial audit report? So the next, we'll talk about our most recent meeting. In that meeting, we presented two financial packages that for October and November. I'm just gonna, October's in there. I'm not gonna reference that at all. I think November is probably the more relevant report to review. And so I don't have any Darlene references to entertain you with, but we'll just go through these a little bit systematically and start with the balance sheet. And I think there's two things that I wanted to point out on the balance sheet. And one of those is going to be operating cash. You can see our operating cash from the end of the last fiscal year till now has increased by almost $2 million. Now, some of that is allocated cash, and we'll talk about that here towards the end of my presentation or toward the end of my allotted time. But we've seen a good increase of cash. That's a very positive. Performance measure for us. I think the next thing I wanted to point out too is the accounts receivable. That the accounts receivable continues to perform better and better with the collection of our receivables. And if you look back, to last year at the same time, I pulled the report just because I was curious. We're seeing, and we're not always comparing apples to apples here, but just as a point of information, a $2 million improvement in that area. So great work by our team, making sure that we're collecting our receivables timely. We flip now to the income statement, or I should say the statement of revenue and expenditure. Sorry, but we had an overall good performing month. You'll see that our actual month performance, our bottom line revenue was $729,000 compared to a budgeted loss of $197,000. So overall in October, almost $1 million variance over what our projected income was. And just another point of reference to from a year ago when we were, in the thick of some of the issues that we were discussing here as a committee and the performance overall, is that if you look at our year-to-date actual expenditures, we've seen a remarkable improvement for our expenditures. In fact, if you look a year ago, I think we were upwards of $2 million to the better in terms of overall savings, and some of that's related to our reduction in staff, which was no fun. But generally speaking, we've seen, like I said, an over $2 million improvement in terms of just reduction in operating expenditures. Also, another point I wanted to make here is the Medicaid, which we've talked a lot about. We're doing a great job budgeting for Medicaid. Our overall performance this year as it relates to Medicaid, which is something we've had constant conversations as, been able to forecast it very well, and our performance is really on par with where it was last year. So I think we have a better grip of what Medicaid can provide. Hopefully there's some more upside there. I think we're all working towards that, but in terms of forecasting, in terms of our overall performance, we're in a good position at being able to predict what's to come. So the last thing, I'll skip over the cash flow and just straight to the page 31 of the graph on days cash on hand. This is just a simplified metric to kind of give us some direction as to where we're headed or where we'd like to be. Right now, if you look at our unrestricted cash, we've got about 43 days of unrestricted cash on hand, or $7 million. Ultimately, we'd like to have we'd like to have more. So just from we contemplate Medicaid and all of the different pieces that go into that. I think as an organization, it's probably in our best interest to have a little bit more of a buffer there. And so you can kind of see, our goal is to increase that buffer. This year, we've done a really good job doing that. And then we'll continue to do that, I think, throughout this fiscal year. But ultimately, the idea is to grow cash to kind of weather any kind of unusual political storms that may arise or any kind of unusual funding issues that may come up. So with that said, I just want to, congratulate the team. I think we're good, solid financial footing, headed in the right direction, both from a budgeting, and a performance standpoint. So. Any questions?
I'll just make a couple comments. First of all, on the audit, that's great. So congratulations to the staff. The other way, Jim and I talked a little bit this morning too, as an operator, this is how I kind of look at things. So I look at, and you go to the revenue statement, that whether or not it's the month or the year to date, I'll look at both. But if you look at the year to date, if your income is up, operating revenue is up 944,000, and your net operating income is up basically 2.5 million. So in reality, for every dollar we brought in, we were able to reduce our expenses $2.50, almost literally. And so when you look at it, that's phenomenal. You normally don't see increased revenue because we've got increased revenues, whether or not it's visits or encounters, you have costs associated with that. So, and there's always a reason, and trust me, this flows in and out. But when you look at that as a quick glance, that's huge. I mean, when you look at it through November. So congratulations. And I understand it's been a tough year, but to be able to come out and look at it, just as an operator, when I look at my business, if I can increase my revenues and decrease my expenses at the same time, that's a huge win. So congratulations. Just a different way of looking at it.
Any other comments, questions? Jim, do you have anything to add?
I would just say congratulations to the staff. I know last year was tough, but to come through and get a clean audit, I think that's special. Very good. Very good. And we did discuss, Finance Committee did discuss with myself there as a guest, what to think of as cash targets for RiverStone. And we are still well behind where we were pre-pandemic. So as a former hospital bean counter sitting here when COVID arrived and the clinic operation pretty much shut down, that put a real squeeze on the cash inflow. All of that patient revenue was coming in to this organization. And absent the many funds that flowed through the feds to RiverStone, it would have been very difficult to keep it solvent. So then that interrupts all of the patient flow, all the patient flow habits that happened around the country. All the hospitals suffered the same thing. And as restrictions get lifted, patients start coming back. But it's a lengthy time before, it's not like turning a spigot on and they come back. Shutting it down is like turning a spigot off. But it takes a long time for those patient habits to come back and that revenue stream to return. So.
But not only that, once they come back, you have to get them requalified for Medicaid. So it's not, you got to get the traffic in the door, and then the corollary is you have to get them signed about if they qualify.
And that has been a challenge.
Yes. I hear that from every agency in town.
Yeah. Any other comments or questions? Spencer or the staff? Hearing none, I need a motion to accept the Joint Finance Committee notes.
So move.
Second.
All in favor?
Aye.
Need a motion to approve the January 16 Finance Committee notes.
So move.
Second.
All in favor?
Aye.
Need a motion to accept the October 24 statements.
I'll make the motion.
Second.
All in favor?
Aye.
And a motion to approve the November statements.
I'll go. Second.
Second, got it. All in favor?
Aye.
Thank you, everybody. Get ready to change.
We get money.
Oh, okay, I don't see Lionel here. Coach, can you give us, were you able to attend safety last month?
I did, but I hadn't prepared what to say.
I'm happy to provide a summary.
Great, that
Yeah.
would be helpful.
Absolutely. So our last safety and quality meeting was December 3rd. The team, Kelly and Amy, proposed a new presentation schedule and topics for 2025, which was discussed and approved. Then we had a training and facilities update. And so Dustin Schneider, our training coordinator, discussed his efforts to reduce the training burden on our staff. And so he has taken the initiative to reduce the mandatory training total time down 3 hours for next year. And so we've taken a look at what courses and trainings were required by any accreditors or the feds or the state, and tried to remove that training burden from other courses that were out there that we were just taking and having staff take because we always have for one reason or another. So that has gone over well with the staff. Anything we can do to provide them with more time in their day is a positive win. Also discussed new managers training and our new employee orientation changes. And so next week will be our first go at our new employee orientation process. And we've taken a small, monthly process and extended it into a more comprehensive week-long orientation, where each day we will not only include orientation and onboarding work, but also what we have here at RiverStone Health called our Rocket training, which is our organizational culture training, and makes us who we are here at RiverStone Health. And so we've included that as well as HR orientation and de-escalation training. And so last year we trained all employees in Crisis Prevention International, or CPI, de-escalation training, because across the nation, violence against healthcare workers has continued to increase and is still an issue here in Yellowstone County and Billings. And so we've seen a decrease in some of our own issues and aggression towards staff. And part of that is due to the CPI training and the ability of now staff to de-escalate clients and patients, family members, whomever, before they get to that point.
So do you have uniform security here? Or how do you do that?
We do. Yep.
Much like the
So
hospital.
we contract, we contract security. And so they are trained in additional safety protocols, but this was able to help us train our entire staff in how when you're talking to someone, are you actually escalating them instead of, bringing them down and having a more friendly conversation. So it has worked well. In 2025, we've decided not to spend the excess cash on CPI necessarily, but have our own internal training program that'll still meet the needs, still be trauma informed, still provide high quality de-escalation training to our staff. And then continue to always evaluate that. Is it meeting the need? Is it meeting our goals? Do we need to do something different? So that was provided update. And then Dion came and provided a facilities and safety update, talked about new construction and renovations at Senior High School Clinic, our Joliet temporary clinic, as well as the air quality monitoring flag system that we have. That was recently vandalized. And so we're waiting on a new flagpole for that. And so that will be, again, installed on First Avenue, 27th Street corner. And that flag, what's that?
They run into it?
It's very interesting because the wind took it down once, and we put up a stronger pole. And this one was very clearly human caused. And it seems like somebody tried to climb it because it was broken halfway up.
That was gymnastics from the scene.
Yes. So we'll never know. We'll never know. But we continue to have that air quality monitoring flag system there. And then now we will soon have backup generator power to our entire wellness building and clinic facility. So not just in the medical clinic, but we've extended that to cover now the pharmacy and our dental clinic. That's the update. Thanks. Yeah.
Two comments on that meeting. First, when I first joined the quality committee, we used to do a lot of monitoring of patient care in the clinic. And we haven't been doing that the last 2 years. I brought it up and said the clinic board is now doing that. However, I think the Board of Health should at least get a report on what is being done. I think that's an important part of what we do. Second, we had the air quality report. Have we done anything that has improved air quality here?
When you say here, buildings, city buildings?
Yeah. Okay. I mean, we've got someone doing this. What's happened?
So that's one of the places where, as a local health department, we work with DEQ, and it's a shared responsibility. So our part of the state local health department partnership, if you want to call it that, is they have the air testing stations geographically dispersed around the state. So we go out and we monitor the equipment, make sure it's working properly, and do the periodic readings. We also, when and if needed, go to the factories and monitor their equipment. We work with the county emergency preparedness services to issue controlled burn permits and make sure that those are being done in accordance with the state laws and our local regulations. Those are a few. We put out guidance when the air quality drops. So when it's fire season or whatever is impacting air quality, we monitor it. And when it hits certain triggers, we disperse communications to healthcare partners and directly to the community about what people can do to stay safe. If they have underlying conditions that put them at risk for bad outcomes when the air quality decreases. So like we often talk with schools about, when the forest fire smoke rolls in and it's down to the pavement on the streets, is it safe for us to have kids out in football helmets in 100-degree weather? Or do they need to take them and do something inside that day or cancel a practice, that kind of stuff? So that's kind of what we do locally. And then other things we coordinate with DEQ at the state.
Ours is really a monitoring role in partnership with DEQ. So if our sanitarians go out to a grain elevator or a crematorium or a asphalt plant, we're making sure they're in compliance with DEQ regulations. Responding to air quality complaints. If somebody says, well, there's dust, right? Dust is the #1 air quality complaint in the state. And whether is that dust from, our dry, dusty, arid climate, or is that dust from industrial processes or something else? And so our role is really to ensure compliance with that Clean Indoor Air Act, the National Clean Air Act in 1970, and other governmental regulations.
Go ahead.
I was going to say, but about Lane 6, are we still doing it, or is it incorporated in? And the only reason I bring it up is because of the training that you were talking about it.
Yep.
So it's still
an introductory, hey, this is one way that we can focus on continuous quality improvement and process improvement and making things better. And so it's a intro to performance improvement and quality management. And just one tool in the toolbox to say, hey, Lane 6 is not the end all be all, but it's one of the tools that we use at RiverStone Health. And here's how you can think about improving your area on a daily basis.
So Coach, when quality is reported back to Safety and Quality Committee, what kind of metrics are used, or in what context or what form is that reported back?
I'd like to see a report on how many errors there are in the clinic, in the care we give, and what we've done to improve the care, education that goes on, and then how we solve events that shouldn't be happening. What we used to call harm stories, which Felton didn't let me use, and we had to use shared learning stories.
I just want to say, I do think, so the clinic, when you look at our number of incident reports, the clinic, I think in general, the medical world has really embraced this concept of transparency with in medicine. And we report, there are a lot of issues that get, reported appropriately. We want people to report any concern, that they have that might have been, something could have gone better, a missed opportunity. I think it's really important that we continue that culture of transparency across the organization, which is why, because I think that we've adopted it really well over there, but we have very few reports in public health or in WIC or in, within public health or in home care hospice. And we really need to continue to not have this be what is going on just at the clinic, but as an organization, where are all the areas that we've had missed opportunities or could have done something differently, or, relooking at things. That's my only, that's my only ask, is that we don't sort of put it on the clinic for being, the ones to kind of report.
I'm convinced we do really well.
Yeah.
But I do think the reports need to get up to the board.
Well, I think, Coach, correct me if I'm wrong, when you say errors, you're talking about deficiencies, opportunities to do better. And I think you need to quantify those in some way. Not that we want to know every one, but I think you should have broad silos that, whether that's patient care, whether it's a facility issue, a mechanical issue, those type of things, to give us some context.
Yep, and that was presented to the clinic board this month. We have a risk management report, the annual risk management report that just hasn't come up to the board yet, and will come to the next quality and safety meeting. So we presented that. We use a system called RL6, which is a anonymous reporting tool, similar to what the hospitals use up the street. And so we look at all of those incident reports that were submitted. There were a total of 363 in 2024. And so our risk manager is looking at all of those, from anything from a adverse drug reaction to falls or IT issues, good catches, near misses, medication potential issues, conduct, safety and security, patient aggression, or any concerns in diagnosis and treatment. So we're looking at that on a regular basis, again, within the clinic board, because that is their federal purview to do that work. And we do bring that to this board in this body regularly. We haven't done it yet this year.
I think I heard you say it's anonymous. How do you guarantee anonymity, or how do you collect it with nobody's name?
So there's some that people will provide their name, will provide their information. There's others that if they need to provide an anonymous report, they can do that electronic system, and then each manager within the department will get that copy of the report and be able to conduct an investigation. So it's optional to be anonymous.
And so do you have any metrics on the anonymous versus non-anonymous? Which ones,
Yeah.
Is the quality better either way?
We've never historically split it out that way. We don't really respond differentially based on whether it's anonymous or whether there's names. So it's just built into the way the system works. So most of the frontline staff don't actually have to use a login to access this system. They just hit the button on the screen and it takes them right to a reporting page. In that reporting page, they have the option to put in their name or the names of other folks who are involved in the incident. When I read through them, this is anecdotal. Most of the time, people are putting contact information for the people that were involved in the incident, because we really make it a point to approach those, use a system response to approaching those things, as opposed to going straight to an individual person did something wrong, and so we're gonna, bring the hammer down on individuals. We look at what's going on from a system perspective that contributed to something happening or a near miss happening.
But isn't that how you have accountability? Isn't that how you change the culture?
It's a balance, because if you use it as a tool for discipline, then people don't report.
Right. I mean, the reality,
So-
certainly in medical errors, very few medical errors are one person not doing their job. There's been a lot of conversation about this for the last probably 30 years in medicine, and to err is human. And we know, that if you have a system set up that's dependent on one person, the same way that, you don't want, a pilot and an error in, flight that causes a massive plane crash to be related to just one person. So there's a whole system of how we look at concerns that are brought forward that are really looking at the background of the system that has caused that. Now, if it comes down to if it ever came down to one person is intentionally giving, the wrong medication to, someone, well, obviously that gets addressed, but very rarely is an error, reliant on just one person. It's the Swiss cheese, what we call the Swiss cheese effect. Things line up so that the error is able to get through.
And all of these reports come into the risk and compliance office. And so that department takes a look at each of them. They determine, is there another advisory group that needs to be stood up? So in the case of medical items, she'll assemble that group, make sure that we're talking about that. So there is a lot of quality improvement that comes as a result of the risk and compliance office's work to investigate, to recommend, and then to have process improvement going out.
And when I started in medicine, everyone was looking at who made the mistake.
Right.
And now it's shifted to how do we improve the system so it doesn't happen. And I started St. Bede's Quality Committee and was on it for 17 years. And that's basically what it did.
We're not unique in allowing the identified reporting. That is a nearly universal practice in healthcare settings because of these issues. So,
Any other questions or comments about the quality meeting? Good discussion. Hearing none, I'll take a motion to accept the report, the December 3rd report.
So move.
Second. Can I have a second?
Second.
And all in favor?
Aye.
Aye. Mine was not an affirmative that I'm seconding. So. All right, public health, Brent is not here. What is that, lung thing, or what's causing me to cough going around and getting all our board members this month?
There's a lot going on.
So John was at that meeting. He, I'm sure, well, he gave most of the meeting anyway.
Can you give us an update?
Do you need to get some water, John?
I
I was looking for the report. I skipped over it. My Lord. Thank you. What's not happening in public health policy right now? So yes, I gave a legislative update, talked about some upcoming meetings that I talked about at the beginning of this meeting, trips to Helena, trips to Washington, DC, other conversations that we've had with our congressional delegation federally. Also going to have a meeting next week with Senator James' local representative and just catch up before heading to DC the following week. Continue to have conversations on bills that are out there. Our public health staff is continuing to monitor potential bills that will impact the way they do their jobs. There's some conversations on tobacco prevention funding, conversations on tobacco cessation, classification of vapes and other substances. Working together with the Montana Permit Care Association and their legislative lobbying efforts, as well as Confluence, organization of public health organizations across the state, and their lobbying efforts. We have 2 weekly calls now that the Montana legislature is in session, just staying updated on what's coming down the pipe. Yesterday, there was a long hearing on Medicaid expansion and a good hearing with no opposition to Senator Buttry's, Representative Buttry's bill presented as the HELP Act and removing the sunset. So we knew that was coming. We knew that would likely sail through the House of Representatives, and we'll have challenges ahead in the Senate, and then get work done as to what do we put into place in guardrail form, whether that is work requirements, other requirements for able-bodied individuals, et cetera. And so that conversation will take place in the coming months. We also are working with Mike Yankowicz on several bills, whether it's suicide prevention, kratom prevention and protection, as well as work with veterans locally. We'll continue to work with our local delegation and have those conversations. There's also another bill we just got drafted for the expansion of and creation of medical residency slots across the state, and a GME state board that's being drafted by Senator Lenz. So we're going to continue to work with him on that to help guide our teaching health center. We did get a presentation on overdose surveillance, and this is where we received the presentation on air pollution control, and that report is attached. So continuing to do good work and monitor all things policy now that the session in Helena is running at full speed.
Thanks. Yep, good job. Any comments or questions for John? Hearing none, can I get a motion to accept the meeting notes?
So moved. Second.
All in favor?
Aye.
So moved. Okay, governance did not meet, so I'm going to take this couple of minutes to say, see, Mark, I took the liberty of putting you on finance committee. If there are other committees you would like to attend, you can see what the basic committees are now. The big ones are finance, quality, and policy. There are a couple others that are administrative responsibilities like governance, and a couple others mandated in the bylaws, which I think are in your orientation package. But when you make decisions as to where you would like to help this organization, just let me know and I can make it happen. I know how to reach Terry here. Get it done.
Yeah, Terry does all the work.
Okay. Any old business? Hearing none. We've got a calendar in our packet and conflict of interest, which the board members do need to sign. So please.
I'm assuming you have printed copies of that.
Yeah, okay.
Lots of
copies. Get writer's grant here, Aaron. We are ahead of schedule. Thank you. For Mark and Aaron, we have a survey. It'll be on your email, and the email from Gary that had the board package in it. Comment about the quality of the reports in the meeting. one comment I will make is that we should have asked Spencer to be the secretary treasurer a year ago. It's already a much rosier picture, just 1 month in that role.
Right.
It's just a lot of pain.
And on that survey, usually there are only 2 or 3 people who answer. And I'm convinced that many more people have ideas. And I always try and answer that and raise questions, because I think a diverse set of questions helps us improve. And it would be good if John were to name those things at the beginning of the meeting that he learned from the survey, so that it would encourage people to use it.
Yes. I haven't learned anything lately because it's been the same 3 people that have been replying.
You send that notice out after the board meeting.
Yeah, I send it.
So that's not enough.
It is anonymous. Except when it's the same 3 people. I know exactly who's saying what.
They always give the time on when the comment was posted. So you can look through each one and you say, oh, that person, that person, that person, and you can figure out who it was.
You have too much free time.
Yeah. I'm not doing that.
Hey, Steve, there's an advantage to being retired.
I'm going there.
Oh, goodness.
All right. Once upon a time when we were finishing with time to spare, we'd have a round table. Any comments from people at the table, what they thought of the meeting, what they would change? Casey?
I would kill for no audit findings at the city. Usually means we messed up pretty good.
So you can't have Shannon. So, Coach,
Already gave my thoughts.
thanks. Aaron, how was your first meeting with the Board of Health?
Was great. I'm looking forward to learning more.
Good. Mark?
I'm just here to learn.
Okay. Thanks for your participation. Appreciate it. Steve?
No comments.
No international perspective?
Just so that a couple of you know that I'm gone a lot. Half of it's domestically and half of it's internationally. So. But I've called in from all places of the world, haven't I? I called in from South Korea in a bus. So I do try to make it.
Spencer?
Nothing for me.
Okay.
Jim?
Debbie? Thanks, Coach. Debbie, any comment?
No, I'm good. I wasn't there in December, so I'm catching up on a few things, and it's always good to be back and hear of all the updates. So thank you.
You're welcome. Good to have you back. Okay. Anyone from the staff have a comment for the board?
Thank you to our new members.
All right. Thanks, everybody. We are adjourned.